Um, Dr. Suri was called for an urgent thing in Abu Dhabi from the hospital, so that he had to leave, and he sent his deepest apologies. I just got a text from him, an unexpected request, I believe. But that serves us in other ways. May I ask the other panel members to come to the dais, please? And we can go ahead and start the discussion. Let me ask for the panel members, are there any questions or any comments they would like to make?
And its implication in Pakistan are concerned, obviously, I already said, I think cost is a major issue. And probably once the third valve or some of the more locally manufactured valves come into our market, like my valve from India and from China, I think it will become more freely available for the population in general. That's probably one concern for us. And then I think the second thing is that it's a well-known fact that it takes about 200 valves for pretty much all the complications to go down, done by a particular operator or a center, apart from the risk of stroke. The risk of stroke pretty much remains constant no matter how many TAVIs you do. So I think awareness of these complications and probably learning from experiences and also probably learning from other people's experience, I think that should help our physicians more than probably the physicians in US and Europe, because here we already have a very small quantity of patients who are undergoing this procedure. And if every center goes through that same learning curve, I think we can't have this option available for the population in general, because the number of complications are going to be very high. So I think cross-training and stuff like that, I think, is very important for a country like Pakistan.
You know, these are extraordinarily important points. I can't agree with you more. And perhaps I should add that the success of TAVR, unlike in many ways coronary interventions, which we had a decades long of conflict with between interventional cardiology and cardiac surgeons, and there are still many areas that are unresolved. The transcatheter aortic valve replacement was successful because right from the inception it was a very strong collaboration between surgeons and the cardiologists, and the heart team was at the center, and also, as importantly, maybe most importantly, in the United States, United Kingdom, almost all the Western European countries, the governments, through different mechanisms, clearly gave this message. Everybody can't do this. You may be a great center, but if you don't have these qualifications, you won't do this. If you do this, we won't pay. So that, for example, in the United States, the agency that pays the money, because everybody's over 65, they said that, you know, you gotta do this. There are several things. They said that surgeon and cardiologist should work together. There gotta be a heart team that's making the decision, and equally important, you have to put your data into a registry. So these limit the numbers. There are over now 2,000 centers that do angioplasty in the United States, 1,500 surgical centers. We started with 200 centers, maybe less. Now it's about 550 centers that's doing this. So I can't agree with you more, and I think it's an example for all of us in the rest of the world to apply those lessons.
TAVI or TAVR is a very significant change in treatment modalities for patient cardiac care, and there's always a question of conflict of interest when you do a procedure, be it bypass surgery with multivessel heart disease, left main, or TAVR, that you know, who will perform, because of course when a heart team sits down, and you'll find that there are some centers who will not accept you for TAVR, and if you go to another center, they will accept you for TAVR for different reasons. And they might say, okay, he's very emotionally upset and he can't bear it. So the heart team decisions differ from one center to the other. But now with the new trial that it has a great data in low-risk patients, that is again a very big game changer. Like we have cardiac surgeons in, Dr. Hasnath is sitting here, we have cardiac surgeons and Brother Wasim. We have cardiac surgeons in Pakistan. In UK, they're cardiothoracic surgeons. In Turkey, they're cardiothoracic-vascular surgeons. They do peripheral vasculars also. And they also spend a year and they get used to intervention. And so they're cardiovascular, thoracic, and interventionist. So the same guy will decide if this guy needs a EVAR or an open surgical repair. So that's probably the ultimate where you do not have a conflict of interest. You just do what you think is best for the patient. But I think this decision-making heart team has to be very empowered. But having said that, TAVI is a very, very serious procedure. It needs very formal training. It needs a wholehearted support of the system. Otherwise, it is such a drained, resource draining procedure. And it needs so much support from the system that you cannot a few operators cannot perform this procedure.
I think you pointed a very interesting area. That is, I've been in interventional cardiology since 1980s, where there was a lot of conflict between the surgeons and the interventionists. When you look at it from a non-interventional standpoint, what we have done as cardiologists, we have diagnosed the patient, decided on the management, carried out the management, assessed the results of the management, followed the patient. So it was a closed loop. After a while, of course, the people said, what is going on? So I think that if we also do this, I think the difference in TAVR, because it's successful, because other people have eyes on it. Other people with independence, clinical cardiologists, heart failure specialists. So that is absolutely the case. I personally don't have a problem, the background training, but it's not enough to train to do the TAVR. The technical part is not really, it is important, but now that systems are so user-friendly, you can learn that in a reasonable time. But the judgment and how to select patients, how to understand the imaging, so that requires one person at this day and age can't do aortic stenting and bypass surgery and valve surgery and intervention. That's the specialization. So I can't agree with you more. If you have any comments, please do.
I have a feeling that surgical AVR will probably become a thing of the past very soon. Even if you take the airline pilots, none of them wants to have a metal valve, because if they get a metal valve, they get on warfarin, they cannot fly. So all of them are getting a tissue valve, and they're very convinced that, okay, if this gets bad, we can always put a valve in valve. And so I think with the new data for low-risk patients, we've been used to this complication rate in the elderly, frail people. So if we start doing it in a younger population, the risk complication will be much less. Procedure will be easier. Whether the price comes down or not, I'm not sure. We might have more competition, but still again, it'd be like this Zion's stent versus some Me Too stents. We still won't have faith in the Chinese and all those other stents.
Actually, MyWell has a lot of data.
Yeah, of
The
course.
Indian MyWell.
Yeah, of course they have a lot of data. In the end, it'll be like, okay, if somebody has the money, get the brand leader. If somebody doesn't, then go to the next generation. So I think the prices will come down, and I really foresee that the surgical AVR will become a thing of the past very soon, and this will become a very, very common procedure. And the only question is that if you use this valve in a younger population, the tissue valve will last maybe a decade or so. So what's the big deal? You put a valve in valve. So if somebody is like 60, gets a tissue valve, at 70 gets another valve, and he touches 80, and then, well, people got 4 valves.
Let me give a bit of caution, if I may. Paravalvular leak is still about 4% with core valve with the Evolut R, and it's still about slightly less than 1% in Sapien. Yeah. And this results in centers that have probably done at least 500, 800 cases under their belts, very capable centers, highly selected. Not heavily calcified valves were excluded, bicuspid valves were excluded. So, but we have very clear evidence that 1 to 2 years, we can show a clear mortality difference between patients who had paravalvular leak and those who didn't have paravalvular leak, moderate or more. But if you go back and look at our earlier study we published from Partner 2, that there is evidence that mild aortic regurgitation may very well cause in the long run, particularly in patients who are not prepared with previous aortic regurgitation. So that is one issue that I'm concerned. We didn't eliminate that yet. The second, very bothersome, is the conduction system abnormality. Now there is data recently published by Tamim in European Heart Journal that the pacemakers, if you follow them enough in the Partner 2 trial, that they have increased mortality. Well, we can say that there is no difference in the at least S3 valve, but S3 valve in the last low-risk trial showed that there was 22% left bundle branch block compared to 5% left bundle branch block. And left bundle branch block is also, there are studies that showing that may be mortal. So when you deal with that, and also the population in these low-risk trials were 73 years old. They weren't 65 years old. So I think we have to be cautious. Another worry is, yes, we can put valve in a surgically placed valve safely, very safely, probably high pressure gradient, resultant pressure gradient. But where the problem is, when we have a TAVR is a completely different animal. If you have a core valve, I mean, if you put another valve, that's a problem. Even if your sapien valve goes beyond the coronary arteries and the sinus of Valsalva is not large, you create a tube. So I think that we are gonna have the surgeons around for a while, but we certainly are taking ways. I think that we have maybe a minute or two. Any question from the audience?
Yes, just one question. In a patient with severe aortic stenosis, when would you like to intervene when there is severe secondary MR? And would that be DVR or mitral clip?
Okay.
So, so in somebody with severe MR, and obviously you have to figure out first if it's functional or primary.
I'm saying
if it's
secondary.
Secondary. So if it's secondary MR, you have to do the TAVI first. Once you have done TAVI, then you have to give it a few months. If the MR does not recover or come down to at least mild to moderate, then these patients should be considered for mitral clipping.
But we know that in functional MR, maybe I was paying attention to something else. A good portion of the functional MR improve.
That's why I said you need to wait for a couple of months. And then one of the good predictors of how these patients are going to do if you do clipping for functional MR is what we call as disproportionate MR. If you have LV end diastolic volume more than 140 with severe MR, these patients are not going to do well with clipping. If the LV end diastolic volume is less than 140 and you have severe MR, these are disproportionate MRs. So essentially it means the LV hasn't ballooned out yet. So these are the patients you would consider for clipping. If the LV end diastolic volume is too high already, you won't really get much out of it. That's where the difference between COAP trial and MITRA FR came.
Any further questions? We have started about 8 minutes late, so we have a few more minutes to discuss.
I think the limitation factor in this part of the world, especially in this country where the resources are very limited, then cost is the major issue. If you compare it with the surgical intervention and then doing the TAVR or TAVI, then I think surgery is much, much cheaper than the here. Unless I think the price comes down and it becomes affordable and it suits my budget, the hospital budget, we are going to start this program. But I think here in Pakistan, it usually costs you more than you can afford. Not even I think sponsors can't afford it, whether it's the government or multinational companies. So I think especially in this part of the world, you have to bring down the special prices for this valve if you want this program to proceed. because then if give you a comparison of the cost of the procedure to the patient, then it certainly would go for the surgery rather than go for the TAVI or TAVR. Thank you.
So one second, and I'll give it to you. I think very important point. I completely agree with you. I think it is exorbitant even in the United States. But having said that, I think if, say, in Pakistan, if I identify two or three centers that do only in prohibitive risk or extremely high-risk patients that are viable, you know, if you fix the aortic valve, they're going to live another 5 years or 3 years, so that we are not all way behind. When the pressure drops, then you don't have the expertise.
You know, the price of these valves is like that of the iPhone. You have a new iPhone and the previous iPhone prices drop. With the Evolutar coming out, the Medtronic offered NICVD, the core valve which they were selling for 25 lakh or $25,000 at that time to 6 lakh rupees. And say it's a one-time offer, you can have a bulk. So I think now with the Evolut Pro coming out, they will plus, you know, they'd probably drop the price of the previous one. So if a system is ready, they can buy the last year's iPhone and use it, and you know it'll be much cheaper. And with the
It's
Chinese,
still good enough, yeah, because the trials are with those ones, yeah.
Thank you. Thank you. Before we finish, I am going to go to Abu Dhabi and ask my colleagues, can you hear me?
Yes,
We can see you and hear you. So if you can just give brief comments, anything that we missed or anything you want to add?
I think a lot of the comments are very well heard here and appreciated. I think here in Abu Dhabi, where resources are a little bit more pronounced, we have the resources is not the biggest limitation. We see multiple centers coming online with TAVR, but I think what we kind of, to summarize everybody's perspective, is that I think with the restrictions we have here, I think we need to focus on very small centers, or sorry, big centers who do a high volume to achieve the best outcomes. I think so we have the kind of the opposite perspective of Pakistan. Resources are very widely available, and so now we need to restrict to high quality centers to get the best outcomes.
Agreed.
Gopal?
Yeah, I'm not closing the door on surgery. I'm going to struggle away here, but you know, realistically, we need to do what's best for patients, and there will be a significant increase in TAVR, and appropriately so. All the caveats are certainly well taken, you know, as I mentioned in my slides, and I think some of the current limitations are limitations of the technology, and I'm very confident that anything local, like anatomic, you know, ingenuity will overcome that. Any
further comments, Ahmed or Bafadel?
Yes, so from imaging perspective, I just want to add that TAVR was the first like heart valve collaboration, but now we have more advanced structural program in terms of dealing with mitral and tricuspid valve diseases, including actually starting doing now like cardiobands and more advanced therapy, especially for tricuspid valve, which is not widely available in the area. And Dr. Mahmood here can add on the other valve structure program that we have.
Yeah, I mean, I just think, just like everything else, I think the proper collaboration, teamwork, kind of is how you build these programs, and without utilizing every resource and every ability that you have to kind of optimize the results, these programs don't get off the ground in a proper way.
Thank you very much. Well, thank you, and let me finish by again expressing our gratitude to our hosts to invite us for this important meeting and giving us the chance to interact with you and to meet with you all. Thank you indeed.
Thank you very much.
Thank you.